My name is Hamzeh. I'm a member of the ACP Trainees Committee and an SPR in Medical Oncology at the Royal Marsden. I'll be chairing this evening's session. So this evening's webinar will provide you with an overview of upper GI cancer management, both in the early and advanced disease setting. The educational content of this evening's meeting are entirely non-promotional, but we are proud to have our webinar series sponsored by Eisai and Roche, world leaders in oncology pharmaceuticals. So our webinars are recorded and will be made available on EBN Health ACP Library website within a couple of weeks. So do look out for that. This is all free content for ACP members, and you can access all of the ACP problem-solving oncology series within the online library. With the housekeeping out of the way, I've now got the pleasure to introduce our first speaker of the evening. So Professor Mansoor is a consultant medical oncologist at the Christie Hospital. He leads the upper GI department at the Christie, and until recently was clinical director of medical oncology. Professor Mansoor moved to Manchester in 1998 to undertake a PhD exploring genetically modified chimeric T cells directed against upper GI cancers. As a consultant, he has continued his interest in upper GI cancers. His research now explores the T cell receptor repertoire and immune microenvironment within immune responsive versus immune resistant patients. He also undertakes research related to nutrition and cancer cachexia, and he's also developed an interest in lung neuroendocrine tumors and built up one of the largest lung NET practices in the UK. Professor Mansoor is also involved in training and education and has previously been the Northwest Training Program Director for Medical Oncology. This evening, he will be talking to us about the management of early upper GI cancers. So without further ado, Professor Mansoor, when you're ready, over to you. Please go ahead and share your slides.
Thank you very much for your very kind introduction, Hamzeh. That's much appreciated. So thank you for inviting me to give you this talk. So I'm going to talk about the treatment of upper GI cancers in their early stages. There we go. So these are my disclosures. So I'm going to start on this slide, which is quite a basic slide, but it will help me explain to you why I've narrowed the scope of this talk. We know that squamous cancers and adenocarcinomas arise from the same anatomy, but they are two epidemiologically and pathologically very distinct diseases. So we know that squamous cancers, they are instigated by alcohol, tobacco, and thermal injury, and they cause squamous hyperplasia, followed by squamous dysplasia, followed by cancer. Whereas the adenocarcinomas, they occur due to reflux and possibly truncal obesity, and they cause dysplasia through Barrett's esophagus and then cancer. It's important to note that the squamous cancers, they can behave in two different ways. They can be very locally advancing, or they can be systemic disorders, whereas adenocarcinomas, they tend to be systemic disorders. And so for the sake of getting through this talk in 25 minutes, I've limited the talk to early cancers, which are adenocarcinomas, but more so really systemic disorders, okay, that are caught in their local state. And I really want to convince you that these conditions need to be regarded as systemic disorders right from offset. And you really need to use effective systemic chemotherapies in trying to get rid of these cancers in their early state. There will be minimal coverage of squamous cancers in their localized state, and that's largely because they are quite poorly understood. It's not really understood why there is a cohort of these cancers that don't spread, and why there is a cohort that only locally advance. And really, they are treated as locally advancing cancers, and so the surgeons and the radiotherapists are probably better placed to explain how you treat these cancers. So I'm going to cover the systemic adenocarcinomas and their early states. So survival rates for esophagogastric cancers in their early state, if you look at the data, then you can see that esophagus and the stomach, the outcomes are very poor, even for stage 1 cancers. So 53% of the esophageal cancers still relapse at stage 1, and stomach it's 65%, despite so-called R0 resections. So why do patients with localized cancers relapse? Predominantly, this is because of metastatic relapse. And the trials would suggest that between 40 and 95% of the relapses we get are due to distant metastatic relapse. So this really is indicative that adenocarcinoma, even in its early stages, is really a systemic disorder. And so for the stage 1 to 3 cancers, what we really need to understand is what we really mean by the phrase M0 in this so-called TNM classification. And there's a number of ways we can look at the M0 status in these patients. The first is a very theoretical way, and so we can look at the M status using at a molecular level, so at a cellular level rather. So if you plot a graph of number of tumor cells against time, then an average patient presenting with a localized cancer will present with about 10 to the power 14 cells, and so that's demarcated by the yellow dot with the red circle around it. And so when you start treatment, of course, we might want to give them chemotherapy to start the ball rolling with their pathway. We will then cause a modest reduction in that tumor cell number, and so that's demarcated by the second yellow dot. And then, of course, we will employ the surgeons to do a large amount of that debulking, and I use that word very carefully, debulking. So the surgeons will eradicate what they can see, and so sometimes we call that an R0 resection. But you'll note that the depth of response hasn't quite reached the bottom. And so the cells that are remaining, which I would call micrometastatic disease, will eventually start to grow and grow to a point where they will reach a critical number of cells, which is lethal to that patient. And that's normally about 10 to the power 19 tumor cells. And once that patient dies, then of course we designate the overall survival. If we use better treatments, better chemotherapies and better surgical techniques, we might get a deeper depth of response, and therefore we might change the overall survival for patient improvement. But you'll note that we still haven't reached 0 cells at the nadir. And it's this residual invisible tumor that we can't see and we don't really appreciate in the TNM classification that really causes problems. And the only way to get rid of that is by using better chemotherapies. You can't do this with localized treatments because this is systemic. And so we really need to understand how to improve the systemic chemotherapy in order to get rid of this residual tumor. So another way of looking at this is by looking at the staging, the classification. Okay, so this is the TNM7 classification. It's a little outdated, but it still kind of says the same thing. So as we go down from stage 1 to stage 4, I'm saying that the likelihood of micrometastatic disease increases, even though from stage 1A to stage 3C, they are designated as having an M0 status. So as we go from stage 1 to 3, what I'm basically saying is that the M0 status becomes less reliable, and really we should be considering at some point that the person may well have M1 disease. And that can be seen when we look at the stage-related survival outcomes. We know that as we go down the TNM classification, the curative success diminishes. So it's almost as if we need a traffic light system to warn us that as we go down the TNM classification, there is an increasing need for effective systemic treatments to deal with a systemic disorder, as well as the surgical or the radiotherapy techniques to get rid of the localized disorder. And the final way that we can look at the M stage is through the MDM, the multidisciplinary meeting. So these are meetings that we have every week, and for 20 years I can recall nearly every week the surgeon, the radiotherapist, and the chemotherapist will have discussions and arguments about whether there is clinical equipoise in treating a certain patient with a certain stage of localized disease. So once again, if I pull up that staging classification again, Where there is no clinical equipoise is in stage 4 cancer. Without any argument, we know that these patients need palliative chemotherapy. But on the polar opposite end of that, where arguably there is no argument that these patients don't require any systemic chemotherapy, is those patients that have stage 1 disease, where this is believed to be the dominion of the surgeon and the radiotherapist. And so without argument, the MDT will decide that for those patients, there is curative intent, and those patients should either go to the surgeon or the chemoradiotherapist. And of course, the patients really like that. They like the idea of avoiding chemotherapy. But when you look at the survival data doesn't quite speak the same language. So the survival data suggests that between 15 and 35% of even these patients relapse. And that's largely because they have micrometastatic disease, as designated by that little red spot in the man. And of course, as we go down the TNM classification, the amount of micrometastatic disease increases, and that really increases the requirement for us to be using chemotherapy. And for academics, what we should really be asking as we go down the staging is, what is a reasonable level of intervention at each stage? In other words, how many patients do we need to treat to get one expected result? So what is the role of systemic therapy in the radical setting? So over the last 30 to 40 years, we have employed neoadjuvant strategies. So OYO2 was a standard of care many years ago. OYO5 didn't quite reach standard of care, but these are examples of neoadjuvant studies that we have tried and tested. The most successful strategy that we've employed is perioperative chemotherapy, and we know David Cunningham's MAGIC protocol was standard of care treatment for a long time in the UK, and now it's been superseded by FLOT4. But of course, a new kid on the block has been trimodality chemoradiotherapy, which seemed to split opinions across the country. I'm going to return back to FLOT4 and CROSS because there seems to be an equipoise issue between these two studies, certainly in the MDT. But I wouldn't leave this without talking about adjuvant treatment. So in Southeast Asia, where the strategy and the trials are mostly influenced by screening programs, largely because they pick patients up a lot earlier than in the West, they are dominated by adjuvant studies. And so there are a number of adjuvant studies, but really the adjuvant study that we want to focus on is the Checkmate 577 trial, because between that, FLOT and the CROSS study, we really need a consensus agreement about what to use and when to use. In meta-analysis, we know that adjuvant treatments are useful in about 6% of patients, but the meta-analysis was influenced strongly by Southeast Asian studies. In the UK, there is some consensus that in patients that have undergone surgery, adjuvant chemotherapy has a role where perioperative chemotherapy has not been given. So let's start with FLOT. So FLOT chemotherapy, so Al-Batran et al. Published this a few years ago in 2019. And so there was an unmet need at the time where the MAGIC protocol, we know its 5-year survival was quite good at 36%, but not quite good enough. And so this was a study basically comparing perioperative FLOT to perioperative ECX chemotherapy. And the primary endpoint was overall survival. And it's important to say this was intention to treat. For all those networks that don't sometimes give the adjuvant arm of the FLOT chemotherapy. It was intention to treat. So the FLOT study was a very positive study. It certainly was better than the ECF or ECX chemotherapy. The hazard ratio was reasonable at 0.77. The 5-year overall survival, 36% versus 45% in favour of FLOT. And the disease-free survival was also favourable with a reasonable hazard ratio of 0.75. And so that became the standard of care. So what's the problem with FLOT? So many networks, I understand, are reluctant sometimes to use FLOT chemotherapy because they believe it's quite toxic. So if we look at that more carefully, you can see from this that the number of patients within the FLOT study that started preoperative chemotherapy, very similar for FLOT and for ECF, ECX. Post-operative chemotherapy, more patients started FLOT chemotherapy than started the ECF or ECX chemotherapy, and certainly more patients completed the FLOT. And so from that point of view, FLOT possibly is possibly better to give. And if you look at the real world, so this is just a Christie FLOT audit, we can see that the real world evidence is quite similar to the trial evidence. It is acknowledged that there are differences between FLOT and ECX in terms of toxicity, but the serious adverse events were quite similar. Bone marrow related toxicity is more common in FLOT chemotherapy, and GI toxicity more common in using ECF or ECX. But giving primary prophylaxis GCSF really sorts out that bone marrow toxicity quite quickly, and so really isn't a problem. If you look at the surgical outcomes of the FLOT4 trial, you can see that FLOT probably does have an advantage. So number of patients proceeding to surgery, quite similar in the two arms, but the rate of resectional surgery was much better for FLOT, and the rate of R0 resections was also better for FLOT. It also had a slight edge in 30 to 90-day mortality. So that's FLOT. So the next one we're going to quickly discuss is the CROSS regimen. Okay, so this was a phase 3 study looking at neoadjuvant chemoradiotherapy versus surgery in patients who had localized squamous cancer or adenocarcinomas. 70% of the patients were adenocarcinomas. And you can see that the primary endpoint was overall survival. The long-term survival outcomes were very good, 47% versus 34% 5-year survival. And that was all statistically significant with a low hazard ratio of 0.66, which is extremely acceptable. So what's the issue with CROSS? Well, one of the problems with CROSS is the comparator arm. Was this a useful comparator? MAGIC was already an accepted standard of care treatment since 2006. This trial was published in 2014, so really it is arguable that they didn't use the right comparator. But the real problem with the CROSS regimen is the chemotherapy that they used within the chemoradiotherapy. So if we accept that this is a micrometastatic condition, it's a systemic disorder, even if it's a localized stage, then using carboplatin with an AUC of 2 and paclitaxel at a dose of 50 milligrams per meter squared is really quite subtherapeutic. And really these were used to radiosensitize rather than to consider dealing with the micrometastatic condition. And if you look at the patterns of recurrence, that really is underlined. So if you look at, bearing in mind that 75% of the patients were adenocarcinomas, and I've already said that I think they have a micrometastatic condition to them. Localized relapse, much better with the chemoradiotherapy than the surgery alone. That's good. But if you look at distant relapse, the chemotherapy had practically no effect on the micrometastatic condition. Both arms relapsed at the same rate. And so because of the comparator arm within the CROSS study, which wasn't believed by many to be adequate, NeoAGES came along. So this was done by John Reynolds and the Irish group, looking at the CROSS and comparing it to largely the MAGIC protocol, so the trial that CROSS should have been. And so this trial, in the second futility analysis presented in ASCO in 2020, showed that the two arms, there was no difference in terms of overall survival. There's no evidence that arm A was unacceptably inferior to arm B. And we have to remember that arm A was predominantly ECF, ECX, so the MAGIC protocol. Halfway through the trial had to undergo a huge amendment to allow FLOT patients in, but we only managed to recruit 27 patients before the trial was closed. So really this was a trial of cross versus MAGIC. So there's no significant differences in complications, etc. And it's interesting what the authors wrote. The pattern of recurrence data may explain the paradox of how improved proxies of oncological impact in cross does not translate into survival advantages. In other words, path CRs, etc., greater R0 resections don't really translate to better outcomes. And so NeoAGES really underlines the fact that cross possibly is possibly an inferior treatment to FLOT. So what if you add in to cross, which is an effective locally controlling regimen, a systemic treatment, a proper systemic treatment? And of course, then you're describing Checkmate 577, because that's exactly what that was. So this was a phase 3 trial, randomized double-blind placebo-controlled study looking at patients that had the cross regimen, and then they were randomized 2-to-1 to either receive a year of nivolumab versus a year of placebo. And the primary endpoint was disease-free survival. And if you look at the results with adenocarcinomas, so with the cross regimen, the median disease-free survival was 11.1 months compared to 19.4 months. So a hazard ratio of 0.75, very acceptable. But with the squames, even better. And the squames we know are much more immunosensitive, but the disease-free survival was almost tripled, 11 months versus 29.7 months, with a very low hazard ratio. And so really that marks the end of cross for someone like me. And what if you improve the effect of the systemic treatment? So we know that with nivolumab, CPS PD-L1 is a reasonable biomarker, and if it's greater than 5, we know that it has reasonable activity and is a reasonable predictor of efficacy. And so predominantly this was adenocarcinomas. With the patients who had a CPS PD-L1 score of greater than 5, you can see the median disease-free survival goes from about 19.4 months to 29.4 months, which really kind of underlines this micrometastatic condition that requires treatments. So how does all of this change our standard of care practice? Well, for FLOT, generally, this should be offered really to all patients with adenocarcinoma, low-stage patients, case-by-case discussion. Checkmate 577, which was approved in mid-2021, generally is offered to all appropriate squamous cell cancer patients, certainly in Manchester, and there should be a case-by-case discussion for adenocarcinomas where FLOT is not deemed appropriate. And the cross regimen should really now be consigned to squamous cancers where IO is not appropriate and certainly possibly not considered for adenocarcinomas. So what's new in this space? So very briefly, so this was a trial very similar to Checkmate 577, but with the addition of trastuzumab. So this was the RTOG 1010 study, where they added trastuzumab to the cross regimen. So it was plus or minus trastuzumab, cross plus or minus trastuzumab for HER2 positive patients. It didn't meet its primary endpoint, and it didn't meet its secondary endpoints. And why? Well, the addition of trastuzumab really didn't cycle the cancer. And why do I think that is? It's once again, I think trastuzumab does need active chemotherapy for it to work properly. We know it doesn't work as a single agent. It needs bona fide chemotherapy. And so paclitaxel at that dose with carboplatin at that dose possibly didn't get the trastuzumab working. Another trial with a little bit more success was the FLOT7 or the Ramses study, which was basically perioperative FLOT chemotherapy plus or minus ramucirumab. And so with this trial, it didn't meet its primary endpoint, but there was a significant improvement in our resection rates. And so possibly this was a phase 2 trial. So possibly there is enough reason to go to phase 3 with this. But one thing that we should briefly touch on is the state, that is the MMR status. So looking at microsatellite instability. So MSI high patients in the resectable situation, MSI high may well point to a prognostic and predictive factor. So this is Lizzie Smythe's work presented in the JCO, where 4 trials were looked at, and the MSI high patients were taken from those studies. And what it showed was that MSI high patients, those patients that had this, it was a reasonable prognostic marker, although it was only prevalent in about 7% of patients. It may well be higher in the gastric cohort, but it does seem to be a robust prognostic marker. But more importantly, it may have an influence on the chemotherapies that we give. And so patients that were MSI high seem to be disadvantaged from having chemotherapy as compared to MSI low patients. And it's believed to be a cross mechanism between MSI high patients and 5FU. So that's something that needs to be looked at. But what this suggests is that perhaps we should be doing MMR or MSI status on our resectable patients to better understand them. Just sticking to that theme of the MSI high patients, so this is the NeoNePIGA trial published in the JCO very recently. So this is a French study where they took 32 patients who were MSI high with localized adenocarcinomas, and they gave them dual checkpoint inhibitors, fairly standard dose of nivolumab and ipilimumab, and basically attained a 60% pathological complete response rate, and actually an 80% very good response rate with the tumor regression grade of 1 or 2. So really that is quite tantalizing in terms of what the future might look like, and the toxicities seem to be quite acceptable. So what does the future look like? Well, I'm not going to go through all of these for the sake of time, but I've covered some of these. But the trials that are probably going to make a reasonable impact on our standard of care are certainly going to be trials like the Keynote 585, which will read out in about 3 years' time, Matterhorn trial, which is recently closed, NeoNePIGA I've just presented, and certainly the Vestige trial, and perhaps innovation if that ever closes. But generally, the message to take from here is we are not quite ready to discard chemotherapy. Chemotherapy does still form the backbone of treatment of these cancers. So in conclusion, the adenocarcinomas, perioperative FLOT chemotherapy should really still be the standard of care. For those patients where they can't have FLOT, then checkmate 577 should be considered, but certainly this should be the standard of care for the squamous cancers that are resectable. For the surgically resected patients, it's certainly worth considering adjuvant chemotherapy based on either the classic study or even FLOT4. And for those patients where we think they are borderline metastatic already, we should be much better at considering them for just palliation, or perhaps even the Vestige trial. And for the MSI patients who have already kind of gone through this, should we be offering them chemotherapy? And we all look forward to a phase 3 study based on the NeoNePIGA trial. I think that's the end. Thank you very much.
Thank you very much, Professor Mansoor. That was a really excellent and detailed overview on early localized esophageal cancer. So we can open up to the floor for questions. One takeaway that I was thinking about, that it's really helpful to have that concept that localized esophageal cancer is a micrometastatic disease. I think that's really helpful to have in the back of one's mind. Whilst we wait for questions, I guess I could ask a question. I wondered if we could just get some further thoughts from you in relation to that equipoise with in relation to kind of with the adenocarcinomas, in relation to FLOT versus now we've got data with Checkmate 577, which included adenocarcinomas. And I think in your talk you mentioned that you would still kind of be favoring towards FLOT, except for in certain specific cases. Just wondered what you base your decisions on, and if like you have a very educated patient who kind of asks about that, and would you discuss the Checkmate option as a potential option? I guess eventually there'll be data kind of because it hasn't been tested head to head yet, but in the current time, what would you suggest?
Yeah, so that's a good question. So I think firstly, the Checkmate 577 trial, what has to be understood about that is it's a grueling schedule. It's a trimodal therapy, and then you ask the patient to go on for a year's worth of immunotherapy. So that's the first thing. The second thing to be understood is that if you use the immunotherapy up front in that stage of cancer, and we know that about 50% of our patients relapse, then you are possibly using up one of the treatments that you might have wanted to use up, i.e. immunotherapy at relapse. So that's the other thing. And the third thing is that I think the 585, when that comes through, that will guide us in a much more informed manner than I can with what we should be doing with immunotherapy in time.
That's great. Thank you very much for your answer. So we have a question from Arun Prasad Peru. Dear Prof, we use DOAC along with neoadjuvant chemotherapy on this group of patients. What's your thoughts about this? So
yeah, so I wonder if the questioner comes from Hull, maybe, I don't know. So I know some parts of the country are very keen on using DOACs. I have no feelings either way about that. I think it's a good idea. We know that these cancers and the treatments are clot forming, and we know that can be problematic. I look forward to adaspirin reading out one day. That would be interesting, but I have no feelings. We don't use it, but yeah, it's a good thought though.
Sure. Okay. Any other questions or any other comments?
So I might ask as a question. The squamous cancer of the esophagus, there's a bit of a split in the country, 50-50, between definitive chemo-rad, organ preservation, versus some form of neoadjuvant chemoradiotherapy, and now with Checkmate 577 and surgery always being part of the paradigm. And what do you do in Manchester, and what's your feeling about that?
So I'm pushing people heavily towards Checkmate 577, and I'm trying to convince people that the disease-free survival is so intriguing that it's really difficult not to justify trying to get Checkmate 577 become the standard of care. But it's grueling, and therefore the surgeons and the CNSs need to pre-warn patients that this is a marathon, this is a long treatment schedule. That's the issue with this particular regimen.
And you think that surgery should always be part of the paradigm for squamous cell cancer that looks like it could be resected?
Yeah, so organ preservation versus getting rid of the organ is an important question, and personal choice for patients. But I think for small cancers that are lymph node predominant, then it should be Checkmate 577. For large cancers, I think chemoradiotherapy with the conventional doses of chemotherapy probably is the better way forward.
I agree with you. I think our MDT discussions have become a lot more complicated since Checkmate 577 came along. And I think you're quite right. We do an MDT case by case for the adenos, probably not the ones that are type 3 into the stomach. It's really the lower esophageal ones that look smaller and suitable for chemoradiotherapy to then be followed by immunotherapy. And it makes the discussions in clinics, I find them enjoyable discussions, but it makes them longer in terms of the choice where to go.
Yeah. I think I'd like the focus now to go up to T1B cancers, the T1B adenos, and what we do with them, because previously they were in the domain of surgical resection without anything else. But I think the relapse rates are reasonable enough for us to consider what we should do about them.
Yeah, no, I agree.
So thank you very much. So there is one question from Jennifer Allison, who says, hello, you mentioned regression score identified on the resection specimen. Does this change your approach to giving adjuvant half of the chemo if no response?
So intention to treat means intention to treat. And so regression score isn't the most accurate way of looking at things. And so we really have to be careful not to overread regression score. But I do recognize, TRG 1 and 2, the survival curves are much better for TRG 1 and 2 compared to the rest. But overreading that, there's a pitfall in that. And we have to be careful with that until the tumor regression score methodology improves. I think we have to, I give chemotherapy, yes, is a short answer to that, only because that's what the trial was designed for.
And I would agree with you, Waz. So we do. So I think there's been some over-interpretation of TRG, some nice data, but actually if you look at, I don't think Avani's on the line, but a meta-analysis of all of the kind of neoadjuvant studies that have been led by the UK, lymph node positivity was the single most dominant prognostic factor over and above anything like TRG. And we all see patients in the clinic who tell us the swallow was better with the neoadjuvant chemotherapy, but the TRG is 5. So we, like you, will try and give the postoperative component of treatment. And I think some data from the Algis surgical group, I think we've now managed to persuade the surgeons, because when they look at the data, if the more post-operative treatment people have had, the better the outcome. And so even Tim Underwood was persuaded by this argument recently.
Brilliant.
Great, thank you. So I've got I have the pleasure to now welcome and introduce our second speaker. Dr Nazreen Starling is a consultant medical oncologist at the Royal Marsden NHS Foundation Trust and reader at the ICR. She specialises in the treatment of GI cancers. Dr Starling graduated from UCL and undertook specialist training in medical oncology at the Royal Marsden. Her research interests in GI cancers are focused on novel therapeutics and delivery of individualised medicines to patients with GI cancers. She's the PI on numerous clinical trials in GI cancer. She's also the Associate Director of Clinical Research at the Marsden and serves on the UK NCRI esophagastric and colorectal subgroups. Dr Starling is heavily involved in training and educational roles, including as training lead for the NIHR Biomedical Research Centre, and is one of 4 training programme directors for the South London Medical Oncology Training Programme. The title of her talk this evening is The Management of Advanced Upper GI Cancers. So Dr Starling, when you're ready, please go ahead and share your slides.
So delighted to just talk you through the management of advanced gastroesophageal cancer. There are my disclosures, and what I'd hope to just give you an overview for, and I see a number of names I recognise who are training with me at the moment, to give you a good sense of why we use the chemos we use in sequence. Where have we got to with precision oncology? Where are we going? Why is immuno-oncology changing our field? If we have time, I'll cover a bit about advanced squamous cell cancer. It gets a little bit neglected, but again, big changes here. And then we'll put it all together in a paradigm. What I will say before we launch into data, our esophagogastric cancer, as the term covers everything, right? From the squamous cancer affecting the upper gullet in general, though we rarely see it at the junction. Lower esophageal adenocarcinoma, junctional tumours, which can be classified by Stewart's into type 1, type 2, true junctional, and type 3 more into the cardia, and adenocarcinoma of the stomach. So you can see we see more adenocarcinoma of the stomach, but particularly the junction in the west. And gastric cancer can be histologically divided into intestinal and diffuse presents some challenges. In biology, these cells are sort of all disparate and seeding through the mucosa. And we really haven't had much success with, diffuse targeted therapies to date, but I'm going to show you some data. So before we do, just a quick case, this classic sort of patient we might see in the clinic, 65-year-old male, high BMI, recent ex-smoker. It's amazing how many times people say they're ex-smoker at the point they come to our clinic. Newly diagnosed, poorly differentiated intestinal type adenocarcinoma at the GOJ with a bit of dysphagia, but not too much. And CT shows extensive midline lymphadenopathy, including the left supraclavicular fossa. It's not lymphoma, it's definitely adenocarcinoma. HER2 negative, mismatch repair proficient, PD-L1, CPS6, no DPD mutations, PS1. So what would you offer? So chemo with Capox Folfox, cisplatin, capecitabine chemo, Capox Pembro, Folfox Nivo, or EOX triplet chemo. So yeah, I guess you'd qualify today in the clinic. What would you offer? So most of you guys would offer doublet therapy with Capox or Folfox. Nobody's going for CX. A few would go Capox Pembro. Okay, so we'll pick up why currently that's not an option in the clinic. Folfox Nivo, that's maybe nearly an option in the clinic. And some of you would go with triplet. Okay, so I don't think any of these are wrong, but actually the evidence base doesn't support Capox Pembro currently, and we're just going to go through some of the data. So thank you, that was really helpful. Okay, so firstly, chemotherapy, first and second line. I'm not going to labour on too much about this, but it's just to give you a sense of what our backbone treatments are. So if we think about the first line, across the world now, it's really a platinum, that could be cisplatin or oxaliplatin, and fluoropyrimidine, that could be fluorouracil given in any number of different ways, or capecitabine tablets. So that is globally accepted. But with that, we've really hit a brick wall in terms of median overall survival. That's somewhere between 8-9 months. We couldn't seem to get past 12 months. Perhaps higher in Asia. We always see differences between Asian and Western patients in gastric cancer trials. And I am going to focus in this first section on really adenocarcinoma, gastric and junctional. We used to have a big debate about triplet therapy, the role of epirubicin added or the role of taxane added, big debates at international meetings, lots of very fierce, opposition to epirubicin, particularly from the US. To be honest, it really made no transformational difference. And as we enter the world of combination therapy, particularly chemo-IO, it is easier to build on a doublet than a triplet. So I think that maybe settles that. But, we might pull out individual patients for a triplet approach, particularly if you need a sort of marked debulking. But even at the Marsden, where we established regimens like ECX, EOX, we don't use that anymore. So in terms of second-line options, about 50% of our patients never get past first-line therapy. And I think that's really important to note in the clinic and in terms of managing expectations with an overall survival somewhere around 8-9 months. 50% are fit enough to get to second-line treatment if they want it. And there our options are between taxanes, docetaxel or weekly paclitaxel. That's more tolerable, and that's the one we tend to go for, or irinotecan, which can be given on its own. There's good data for that, or in combination with 5-FU. Often in the UK, FOLFIRI is used. And that has a median overall survival benefit of about a couple of months, okay, from 3 months to around 5 months. Median overall survival. And again, I think those are sort of helpful figures as you navigate these clinics if you're doing GI. What about third line? About 20% of patients might be fit enough for third line treatment, again, if they want it. No treatment is always an option. And the TAG study really brought that to be compared against best supportive care. And again, a delta of about 2 months with median overall survival going from about 3.6 to 5.7 months. It's fair to say the response rates are pretty low with Lonsurf. So if you need debulking for symptom control, you're probably not going to get it with Lonsurf, and particularly with extensive liver metastatic disease, it's unlikely to have a significant benefit, as we know from our colorectal studies. However, although that's FDA and EMA approved, it is not NICE approved. So in our clinics, we're not offering this in the third line setting. If you have a patient fit enough who hasn't had irinotecan in the second line, we might think about it in the third line, but that comes with a careful discussion of the risks and benefits and alternatives, including no treatment. And I think what we're starting to see akin to colorectal cancer is this potential sequential paradigm of first to second to third line in some patients. And with that, and these are Marsden sort of audit data that we did a few years ago by Michael Davidson, if you only have one line of treatment, survival is probably more like 8 months. If you're able to have 2, maybe we get up to more like 15 months. And if you're able to have 3 or more, maybe we're heading up to 20 months towards 2 years. And compared to the 1980s, when best supportive care was really the main offer, median overall survival then was about 3 months. So it's very slow progress. It's not transformational, it's incremental, but maybe chemo-IO and some of the new developments will challenge where we are, where we were. So that's all I'm going to say about chemotherapy. Moving on to targeted treatments, let's really focus on HER2 and VEGF. So HER2 is really the main targeted approach for some patients with gastric and junctional adenocarcinoma. That's 1 in 5 patients may be HER2 positive. We measure that generally by immunohistochemistry, and if it's 2+, we might do FISH to confirm amplification. And in the TOGA study, so this is, I'm going to highlight some of the pivotal studies you really do need to know if you're doing upper GI cancers or for the exam. TOGA brought first-line trastuzumab into practice in addition to fluoropyrimidine platinum-based therapy, and we see an improvement in PFS. Overall survival median goes from 11.1 to 13.8 months, past that 1-year barrier. But actually, if you look at the 3+ patients, the median overall survival is more like 17, 18 months. And I know from my clinic that where we have patients who are really HER2 amplified and their cancer is addicted to that pathway, they may do very well for a reasonable time with this sort of approach. It adds about 10% to response rates. Okay, so that's one pivotal study. These ones I'm going to mention, but you can probably forget about them afterwards. What about additional targeting of HER2 in the first-line setting? We see that a successful approach in breast cancer. Well, the addition of pertuzumab to trastuzumab and chemo did not result in a statistically significant difference, even though these curves separate. So approach in breast cancer, but not an approach in gastric cancer. And then what do we do in the second or subsequent line, but in the second line after somebody's failed on first line HER2 suppression? Well, the Gatsby trial looked at TDM1, another drug used in breast cancer, against paclitaxel, not a successful trial. Probably they should have added to chemo, but this is not an approach that we use in gastric cancer. Gastric cancer HER2 positive and breast cancer HER2 positive are very different diseases. I should say continuing trastuzumab beyond progression, which I sometimes see patients having done, not in the NHS setting, I must say. There is no data to support that. In fact, a randomized phase 2 study suggests there's no benefit, so we shouldn't be advocating that. But what I do think is promising coming through the ranks in the pre-treated setting is this drug, trastuzumab deruxtecan. You've probably heard about it, antibody drug conjugate, HER2 antibody conjugated to exatecan, which is a topoisomerase, so we know those work in gastric cancer. In this study, Destiny Gastric 001, pre-treated population of patients, most had more than 2 lines of therapy, and you can see a definite signal with chemo alone, about 15% response rates, 50% with TDXD. You can see that in the waterfall plot. This was mainly an Asian study, but it did lead to an FDA approval in January 2021 for patients who are HER2 positive and have had previous trastuzumab-based regimen. You can interpret that as second line. I think really this trial supports more a third line approach, and indeed the definitive second line study, Destiny Gastric 004, is currently ongoing, randomizing people between second line paclitaxel versus TDXD, and we're currently recruiting to that, and I'm sure WAS is as well. So this was a predominantly Asian population. We've talked about the differences between Asian and Western patients. So Destiny Gastric 002 was conducted in a purely Western population. This was a second-line setting. Patients had progressed on previous trastuzumab. Importantly, they're all being biopsied again after, if it's in the second line, if they've just had trastuzumab. And this is because loss of the target of HER2 can be a resistance mechanism. So in all of these trials, where in the second line setting, patients are being re-biopsied, and that can be a little problematic. It may not also be completely reflective of the metastatic disease for a reason I'll come to. But here we definitely again see a signal with an overall response rate of just over 40%. If any of you have used this drug, say in breast cancer, you should be aware of the potential risk of ILD, interstitial lung disease. It's about 8 to 10% across all of the Destiny programs with this drug, but it can result in death, and here a 2% rate. And certainly in the trials, there's a complete paranoia about this, I think, justifiably, for early detection, linking with the specialist respiratory teams and sort of adjudication by the company of scans and whether this is heading to ILD. So in clinic, if you have somebody on this, those early warnings, a new cough, a new shortness of breath on exertion, take it very seriously. So moving on to VEGF inhibition, this is the other sort of exploitable approach in gastric-conjunctional adenocarcinoma. You can target VEGF receptors through the ligand, i.e. target bevacizumab against the ligand VEGF, or an antibody against the extracellular component, say for instance ramucirumab. And ramucirumab is what we're going to focus on. So again, pivotal studies you need to know, REGARD and RAINBOW. REGARD brought ramucirumab single agent into practice versus best supportive care in the second-line setting. There was an overall survival increment of 2 months. There's not much in it in terms of response rate. It's pretty well tolerated. It's not NICE approved. Waz and I were on the technology review committee for that, didn't pass the threshold, but it is in the international guidelines, including the updated ESMO guidelines in the second line. To be honest, even when I can use it, I'm rarely using ramucirumab on its own, but there's the data for that. You should know RAINBOW. So this is second-line paclitaxel ramucirumab, and this study brought that into practice. There's a delta again in median overall survival of 2 months, with an overall survival in the study of 9.6 months with the experimental approach. That's probably conflated by the Asian patients, and if you take them out, you still get an overall survival of about 7.6 months, and the delta remains in Western patients. But this didn't pass the threshold for a NICE approval, but it's in all the international guidelines. And when we're running studies with the next new thing, PAC-RAM is considered the standard of care arm for fit patients. So REGARD, RAINBOW, you should know those. In terms of the side effects, these are sort of anti-VEGF type side effects, hypertension, proteinuria. It's pretty well tolerated. In my practice, I think where I can use it, I've seen a little bit more fatigue and perhaps a little bit more thrombocytopenia. So what about if you can't give paclitaxel in the second line? For instance, they've just had a taxane or they've got neuropathy. What about FOLFIRI and ramucirumab? This is a nice randomized phase 2 study from the German group, AIO, of FOLFIRI ram versus PAC-RAM in the second line setting. Doesn't look very impressive, does it, apart from the patients who just received prior docetaxel. And to my mind, this really serves an unmet need for the patients who relapse quickly after perioperative blot. Because they've had the taxane, the fluoropyrimidine, the platinum, really irinotecan is the next drug without cross-resistance, and can we add in ramucirumab? And maybe this is an approach that could be used in the future there that will be defined in an ongoing randomized phase 3 German academic study. So targeting angiogenesis in the second line signal that works. What about the first line? The answer, no. So based on Avogast with bevacizumab and Rainfall with ramucirumab added to the usual chemo backbone in the first line, although there was a signal a bit for Avastin, these were negative. So there is no role to do that in the first line. This is an ongoing study. Some of you may be participating in it. Caroline, who's one of the speakers, has really done a great job with this trial over the last few years. And this is looking at maintenance therapies in the first line setting, one of which is after doublet chemotherapy to de-escalate to CAPE with ramucirumab, and the primary endpoint is PFS. So we're yet to see that report. And what about in the third line angiogenesis inhibition? Well, there's a drug called apatinib. It's a tyrosine kinase receptor, but again, the intracellular component of VEGF2, and worked in a Chinese study, didn't work in a global study. So there's an approval in China, but not in the rest of the world. So we don't recommend that, and it's not in our guidelines. So that's where we've got to with targeted therapy, but where are we going with precision oncology in OG cancers? Now, this is a slide I've used a lot, but across the GI tract, there are distinct actionable genotypes. I think it's fair to say, though, in esophagogastric cancer, really the dominant one today is HER2, and we have some additional things that we can look at which have been come to bear because of tumor agnostic approvals, and I'll come to those in a second. But what we've experienced really over the last decade or more are lots of negative studies of targeted therapies in esophagogastric cancer. I mean, this was a very depressing decade. And we were involved in some of these studies. I think really part of the problem was lack of a selection biomarker that had been really characterized and exploited. So in the EGFR inhibition space, with drugs like Pani or cetuximab, maybe there is actually a signal from the COG study, Russell Petty study, for EGFR amplified patients, but they actually only represent 1 to 3% of the patients we see. But I think that's the reality of precision medicine. The FGFR story is being reignited by a different approach, which we'll come to. And PARP inhibition failed, but we don't think that's dead in the water. And probably DNA damage response needs to be characterized further, and we're doing that in the SOLAR study, which is ongoing. So in terms of things that you should look out for that have completed, we talked earlier about diffuse gastric cancer. Now, this is an interesting drug, zolbetuximab, which is targeted against Claudin 18.2 gap junction protein. There was a very nice signal from this randomized phase 2 study, the FAST study, and that led to a Spotlight, which is a randomized study building on doublet, not EOX, and zolbetuximab. That's fully recruited, and we await those data with interest. If that is a positive study, that will be the first sort of diffuse gastric cancer targeted approach. And FGFR2, I think that's been reignited with these new best-in-class drugs, bemarituzumab, selected by either IHC or gene amplification at the tumor or on ctDNA. We see a very nice study in this signal in this randomized phase 2 study, and therefore the Fortitude study has launched. And we again await those data with interest. We're going to try and participate in that. We're just setting that up at the minute. I'm just going to say something briefly about tumor agnostic approval. So NTRK fusion, I mean, none of it, that we didn't see a gastric cancer patient in these studies, to be honest, but it's there, there's an approval, there are drugs, there's testing, although we're not frequently putting gastric cancer patients through NTRK fusion testing, to be honest, it's probably under 0.1% expression. And again, there's a RET fusion tumor agnostic approval. I can't see any gastric cancer patients in here, and probably these are occurring in a very, very low proportion. But the world of precision medicine would say, well, based on effective or efficient panel, should we not be testing for these for all patients? And I guess that's a debate. So just to summarize that, I think, you know, we've talked about the tumor agnostic approvals. I haven't really talked about TMB high. To be honest, most of our TMB high patients are also MSI high, and we're going to come to that. There's been a bit of a failure of MET targeting and ATM targeting. But how do we do precision approaches in OG cancer in the future? Well, the Korean group, South Korean group trialed this based on IHC markers in the K umbrella trial reported at ASCO, and this was looking at EGFR positivity, PTEN loss, PD-L1, MSI high, EBV, so immune phenotype, but only based on IHC. So a control group where you measure those things, but you just treat with PAT-RAM versus biomarker-led targeted therapy, you know, and it looked impressive, didn't it, with only 30% of patients not having a biomarker, you know, supporting this highly precision approach, but it was a highly negative study. And maybe there was a signal for more EGFR expressed patients, and maybe a signal in the more immune-like patients. But ultimately, whilst it's nice to see you can feasibly recruit to these studies, probably IHC as a selection biomarker is not enough, and K umbrella 2 is really looking at NGS and or ctDNA biomarker selection. And the other major challenge in this disease is heterogeneity. So you can have a biopsy specimen, and even within that, we see different levels of the same biomarker being expressed, HER2 positive in one place, HER2 negative in another. Between the primary and the secondary disease, we can see discordance, and in this very elegant study, up to 30% discordance between the primary and the secondary, and probably the secondary disease revealing more of the molecular aberrations. And maybe ctDNA can help. I don't think it completely circumvents the issues, but maybe ctDNA can help with some of this in terms of that heterogeneity and being able to really pick up the clonal drivers. So that is the challenge for precision medicine. And I think approaches like this is a Japanese study, Godzilla, or choice of name, I think. But anyway, it's based on ctDNA selection. So not really looking at the tissue, just saying if we find it in the blood, we find it in the blood and we're going to act accordingly. And maybe that's a good strategy, because if you find it in the blood, maybe that's the clonal driver. So a number of buckets for molecular aberration and best-in-class drugs, and with a line of sight with this sort of design to a regulatory approval, for instance, FDA. And I think the other interesting thing about this is when they introduced liquid biopsy screening, patient in the clinic, take a blood test, send it off, they really sped up recruitment to this study as opposed to based on tissue profiling. And actually, they see that the response rate increase with a ctDNA guided approach versus a tumor NGS approach. So I think that's interesting. I think that might be part of our future strategy for precision medicine. In the last few minutes, I'll just cover immuno-oncology approaches and how that's transforming the landscape. Immuno-oncology is a broad church. So not only is it immune checkpoint inhibitors, it's cellular therapies, it's virotherapy, etc. But I'm really going to really focus on immune checkpoint inhibitors. You know what these are, lots and lots, more than this list, but probably in this disease, Pembro and Nivo have the lead. There's some new data with tislelizumab, and there's some Chinese anti-PD-1 and PD-L1 antibodies. So the first key thing you need to know is that if your patient has deficient mismatch repair, this study led by one of the US groups, and the OGs in mustard, immunotherapy really works. There's a depth of response. There's a speed that happens somewhere between 8 to 20 weeks, and there's a durability of response. It is a real game changer drug. And we see that in 4% of esophagogastric cancer. So there's an FDA approval, that was the first tumor agnostic approval for pre-treated patients. In fact, with the COVID sort of relaxation of rules, we have more access now to immunotherapy for DMMR patients, actually even in lieu of first-line approaches. So the next study you need to know, and this is why some of you answered, I think, FOLFOX Nivo to that case, that case I presented, is Checkmate 649. So anything with Checkmate is a Nivo study. It's a BMS study. And this is in the first line, HER2 negative, randomizing patients between chemo versus chemo Nivo versus there was an arm with Ipi-Nivo, which was culled. It wasn't successful. And the primary endpoint, dual overall survival PFS, based on a pre-specified group of CPS. So don't forget, you can measure PD-L1 in different ways. You can look at tumor cell only. You can look on the tumor and the immune cell. CPS is a combination of immune and tumor. And there are different antibodies. And this was the 228 antibody versus the one that we use for Pembro. And this was a positive study. So 60% had the biomarker. So you always ask yourself the question, what is the proportion of patients this is relevant to? 60% were PD-L1 greater than or equal to 5. You see a clear separation of the curves in that group. Now the median overall survival breaks past that 12-month barrier, 14.4 months, with a delta of 3. That's starting to pass all the nice criteria for acceptance, even though we're waiting to hear the nice outcome. And actually, if you look at other groups, so CPS greater than or equal to 1, the relationship holds. And all randomized, regardless of CPS, the relationship holds. And we see that mirrored in the PFS. And there aren't any subgroups that don't seem to benefit as much. Some interpret this as the gastric cancer patients benefit more and the junctional don't. I think there's a benefit really for all, including signet cell, which can have a worse prognosis. And on this basis, interestingly, the FDA approved in combination with fluoropyrimidine platinum, regardless of PD-L1. So in the US, you could have a PD-L1 0 patient and you could use this. Whether you should do that or not, that's a different question. EMA have approved, but in PD-L1 greater than or equal to 5, and we're just waiting for the nice final, hopefully, approval. It's the third time back to committee, which suggests there's a lot of cost bargaining going on. We were expecting this months ago, but it's really been pushed back. And it's likely to mirror the EMA approval PD-L1 greater than or equal to 5. And it will be interesting to see if we're tied into the 228 antibody, or we can use the other one. And I say that because pathology labs are finding this kind of challenging. This study, you don't need to commit to memory, but I just think it supports. It's a Japanese study. Attraction means it's always coming from this Japanese group. First-line chemo versus chemo Nivo, and that showed a PFS benefit, which is their primary endpoint. This was irrespective of PD-L1. Didn't show an overall survival benefit, and there may be reasons for that. And there weren't any specific subgroups who didn't appear to benefit. So the other, and I will put this in with the gastric junctional section, is Keynote 590. You do need to know that. I was going on about that in chemo clinic this morning. And this is with pembrolizumab in the first-line setting. So this was actually a study targeted against esophageal cancer, whether it's squamous, which is the majority, or adeno. And it went to type 1, so just above the junction, HER2 negative. Randomizing between chemo, placebo, chemo, immuno. Complex statistical designs, dual primary endpoints, OS, PFS, but pre-specifying squamous cell cancer above CPS above 10, squamous cancer alone, or PDL, regardless of adenosquamous, CPS greater than or equal to 10. And in those groups, we see that definitely in squamous cancers with CPS greater than or equal to 10, we see the biggest benefit. We still see a benefit in squamous cancers regardless. We see that benefit, the split of the curves in any cancer, adenoma or squamous, CPS greater than or equal to 10, and less so in all comers. And just to say that greater than or equal to 10 with this antibody is 51% of the population. If in the subgroup analysis, the adenos do seem to benefit. That's where I first went to when I saw these data. And in terms of CPS, there appears to be much greater benefit, greater than 10 rather than less than 10 in actual post-hoc analysis. We don't see much of a difference for PD-L1 less than 10 in this analysis. So this was approved by the FDA and EMA, a nice approval last year. And interestingly, they didn't limit it to suet type 1 above the junction. They said esophageal or gastroesophageal junctional, which could take you into type 3. So actually, that's probably not a bad thing for patients in terms of access. That wasn't completely faithful to the trial design. And it's probably because it's just very difficult sometimes to tease out if you've got a type 1 or 2 as junctional cancer. In terms of negative studies, why don't we use immuno in the second line setting where Keynote 061 was actually a negative study? The trend, we see the crossing curves, that usually in this disease means that you need chemo to stabilize that patient. And maybe a trend for greater than 10, but we don't have access in the second line. And this is a Japanese study in the third line, Nivo. There's an approval in Japan based on attraction 02. But now that we have immuno first line, this becomes less relevant and is not approved outside of Japan. We did have a pembrolizumab approval by the FDA in the third line, just based on single arm data in PD-L1 expressing patients, but the FDA withdrew that. And again, probably because the landscape's changing and we have access to first line. And what about this confusion about pembro? So pembro in the junction with chemo, CPS greater than or equal to 10 is okay, but in Keynote 062, this was a negative study when chemo placebo was compared against chemo pembro, and that both in CPS greater than or equal to 1, CPS high, and this is a very odd result. I think MSD are repeating a trial like this because this result isn't quite believable given the direction of travel of everything else. I should just say that they also did a non-inferiority comparison between immuno and chemo, and actually that did meet the statistical significance. You see the crossing curve again, and it's much better tolerated, but it's going to be really hard to persuade anyone that that is cost effective, and indeed nobody has tried to persuade anyone. I think you should take note of Keynote 811 of immunotherapy added to first-line chemo trastuzumab. This trial is recruited and we're waiting with bated breath to see if it is a positive study. But just to say, based on the interim results of over 200 patients, where based on overall response rates, you see this quite impressive response rate difference between the pembro group and the non-pembro group. And the FDA approved that. So in the US, you can use that. And actually in insured patients in the UK, we can get access to that. But actually, I'm a little nervous always of treating without seeing the final data. So we do need to see that. I'm just going to skip over cellular therapy, but just watch the Claudin 18.2 space because I think there's some interesting data. And to put that all together, so in the clinic, I've showed you a lot of data. I've showed you some of the key studies, but how do you put it together? So let's start with HER2 negative. In the NHS, in the first line, you've got one of these standard fluoropyrimidine platinum chemos, usually doublet, maybe triplet for selected patients. Whilst we'd like to have access to Pacram, we don't. So in the second line setting, we use paclitaxel on its own, or irinotecan, or docetaxel. In the third line setting, we don't have access to trifluridine tipiracil, so we might use irinotecan if the patient's fit enough, if they haven't had it in the second line. And then in the HER2 positive space, we go CX trastuzumab first line. We don't have HER2 targeted approaches in the second line, and we don't have access to Pac-Ram, which works for HER2 positive patients. So again, it's a similar chemo paradigm, second and third line. We don't have access to TDXD, but put patients into those trials. Those will define the space and watch that space. For DMMR patients, we have access to immunotherapy, and that is a game changer for those patients. And now we should all be testing for PD-L1. Currently in the clinic, if you have a patient with junctional cancer, CPS greater than or equal to 10, it's chemo, pembro, and we're waiting to see what the nice outcome is regarding chemo, nivo. And then in the HER2 positive space with immunotherapy, let's see what the results of Keynote 811 are, and are they going to change the first line treatment? So I think in the interest of time, we don't have time to cover squamous cell cancer, but I think, again, you do need to know, check Keynote 590, so you actually have gone through that. Yeah, Checkmate 648 is about to come on to the so Nivo in the first line setting is about to come on live in the NHS. So it's good to see that, and that threshold is CPS or is it TPS greater than or equal to, so it's a different antibody, different scoring system, tumor cell scoring greater than or equal to 1. And so we just need to see how nice guide us as to the sequencing for Pembro and Nivo, and we do have access to I'll just skip over that, second line immunotherapy in the NHS based on the attraction study. So sorry, I'll just skip over that. So finally, really in conclusion, chemotherapy is it's at its limit. We've got a sequential treatment paradigm, precision medicines possible, but please note heterogeneity and some of the challenges, and we've got to be just a bit clever about selection and trial design. Immunotherapy is redefining the treatment landscape for adeno and squam, and in the clinic you should always be asking yourself, is this patient PD-L1, what's the level, what's the MMR, and what's the HER2 to really define optimal therapy. So thank you for your attention, and sorry to have gone over.
Thank you very much, Noreen. That was a really excellent talk, really clear overview, and really highlights how advanced esophageal cancer is a high unmet need disease, and the importance of clinical trials. So we can open up to questions. We have a question from Hira Youssef. Do we have to do CPS in order to prescribe Nivo as second line? What's the range for CPS?
Yeah, that's a good question. So I'm so sorry we didn't have time to really go over the squamous data, but the second line data for Nivo comes from the attraction study, which doesn't mandate CPS testing. So you can, in the clinic today, if you have a patient second line squamous, you can offer nivolumab. Whether that's the right thing to do or not, I'm not sure, because I think all of the kind of data we're getting from the esophagogastric cancer space suggests, and Waz might have a view, that we need some level of PD-L1 expression for the patient to really derive a benefit. Once these drugs are well tolerated, they're not without side effects. You know, and in our clinic, we are really starting to have to learn to manage in the GI world immunotherapy-related toxicities, colitis, thyroiditis, hypophysitis. You know, we're starting to see everything our colleagues have been seeing and treating for a while. So I don't know if Waz wants to come in on that one, because I know you've been doing a lot of the technology reviews as well.
Yeah, no, thanks, Noreen. Just to kind of say, I'm probably not supposed to say this, but Lonsurf was reappraised this week. So that's third line, and the outcome, I'm probably not supposed to say it, but it's probably going to be positive. It is positive. So Lonsurf is online, and then Checkmate 648. That was an interesting appraisal from NICE with 648, and they did ask, well, what's the sequencing of testing that we want to do? And it was agreed, really, just to get it through, that we would do CPS first, and if that was negative, then we would do TPS. So CPS less than 10, but TPS greater than 1 is about 20% of the patients. And so it was agreed that that's the sequencing that we would do. I did say to them that in reality, people will do them together if they can. But, you know, amount of tissue is going to be a real problem with this now.
And do you think, Waz, on that point, are the pathologists, because they're the ones that are getting all the extra work for this, and there's always pushback in pathology departments as these things come online. Do you think that they're willing, I mean, maybe that they have to, but to have to do 2 different tests? Why can't we just do CPS for all?
Yeah, that's a really good question, Noreen, and that's something that we put to. So the favoured assay is the 28-8. Because it's more positive. And that was a thing that we put to NICE, and they weren't willing to listen to that. But interestingly, I was speaking to Jafar Ajani the other day, and they are moving away from IHC, so immunohistochemical staining, and they're going into multiplexing, so they don't run out of tissue, and the pathologists, it makes their lives a lot easier. But tissue is going to be a real problem for us unless we change our platform.
And I mean, this has come up a lot in discussions with others. What's your feel for the access to PD-L1 testing across the country and the turnaround time?
Not acceptable. So I've lost a lot of hair over this, and I've been asked to write a consensus statement now about it. It's just not acceptable. So I think Birmingham are trying to do their best, UCL are trying to do their best, but they're inundated now. And so the turnaround, I've been told now, is about 3 weeks. And the trials were designed to start the treatment with the IO at offset, and the statement from us should be that that's what we're aiming for. But so I can tell you what people are doing. I've had MHRA permission to harmonize the Ventana machine. So that's the machine to the DACA machine. So just for those people that are listening, these assays have to be done on DACA machines. DACA machines are unreliable. So the NHS have never funded DACA machines, and these assays were done on DACA machines. But we're now being given permission to harmonize the Ventana machines, which are the machines, the platforms that we actually have in the NHS. So once that's validated, it should become a lot easier.
Okay. So I think 648, I think you were one of the experts for that technology appraisal for that's chemo Nevo in the first line squamous. There probably will be a diktat to check CPS first, and if you're over 10, you go chemo pembro. But if you're 1 to 9, you have to then do another test on the tumor cells to do TPS with a different antibody.
That's right, but I don't think there will be a diktat, because I made it clear to them that there mustn't be that, because we're already struggling with just tissue. That if you start limiting it from the nice side of things, they would prefer for us to use pembro, even though the 648 data was a better trial than the 590, because they mixed histology. But we've persuaded them not to dictate to us too much about ordering, but they would like us to consider pembro first based on the 590 data before the 648.
Okay, that's really, and this is all hot off the press, by the way, everybody.
So
that's where it comes to OCT teaching.
That's great, thanks. And just so for people listening, in case anyone, so TPS is tumor PD-L1 proportion score. Is that right?
Yeah, so tumor cell, tumor proportion score. Caroline Fong, I think, is going to talk a bit later, but Caroline became the world's expert on different antibodies as we debated this on platform. So PD-L1 can be expressed on immune cells and tumor cells, and CPS looks at both, and the TPS will really focus on the tumor cell expression. Caroline, if you want to comment.
You're on.
Yeah, thanks, Noreen. So there's just been, as Waz and Noreen have already covered, I think there's just been a lot of debate over which is the better antibody. In terms of data to support, in terms of comparisons, there's no prospective comparison, obviously. There was a recent publication that was presented at ASCO this year from a Singaporean group that showed that the 28.8 is a bit more sensitive than the 22C3, but it will be very difficult trying to tease this apart. Aside from that, the rest of the series that have been published, looking at the different assays, they're quite small. They're sort of 50 patients, sort of that kind of size. So it's really difficult to tease apart. And because scarcity of diagnostic tissue is so, it's precious, you can't go retesting. And then there's obviously the logistics of that as well, and making patients wait for treatment, changing treatment halfway. So it is very difficult. It may be that the more practical way of doing it is using the 28.8, because, as Waz has also just said, the 648 data is a lot more compelling, and that's the antibody they use compared to 590. And that has also been used in Checkmate 649. And you've got a very clear, from a clinical perspective, as a clinician, you've got a very clear demarcation as to which treatment you're going to opt for by histology, and it takes away a bit of that ambiguity in a clinical setting. That's an added bonus to me. But yeah.
And I think there's also a question, isn't there, about the testing, the validation, evaluation of IHG assays
Yes.
like blueprint. Yeah, I mean, I was talking to MSD yesterday, and there probably will be an EQA, I think they call it, in terms of quality assessment of lots of labs having the same specimen and doing the concordance and testing for quality, and that's on the DACO machine that Waz was mentioning. But as you know, TPS comes into, and then the 228 antibody comes into practice for us, then it'll have to be a similar process, I think.
Great. Shall we move on to the final talk, which is Caroline's case presentation? So Dr Caroline Fong is a specialist registrar in medical oncology at the Royal Marsden NHS Foundation Trust. She's recently completed a fellowship in gastrointestinal malignancies at the GI lymphoma unit at the Royal Marsden, and during which she has been a trial physician for the platform study, which Noreen mentioned. This is a multi-center academic trial assessing maintenance therapies in advanced esophagastric adenocarcinoma, and this evening she'll be presenting an upper GI cancer case presentation. So Caroline, when you're ready, please go ahead and share your slides.
Thank you, Hamzeh, and thank you to the ACP Trainee Committee for extending the invitation to myself to present this evening. So I'm going to take you through a case study, which is based on a patient of advanced HER2 positive gastric adenocarcinoma, and just talk through a couple of interesting learning points that I thought were sort of stood out for this case. So without further ado. So just to give a bit of background, in June 2020, a 60-year-old female patient present with a past medical history that was only significant for a left ACL repair. So she's previously fit and well. She's a copywriter. She has 2 adult children, used to smoke socially in her 20s and only drank occasional alcohol. So she presented with symptomatic anemia as well as dysphagia to solids. So she proceeds to have an OGD. This shows that there's been some altered blood in the stomach, but no focal point of bleeding. They also saw a stricture at the GOJ, as well as a large malignant ulcer in the cardia, from which biopsies were taken. So here is her staging imaging. On her CT, on her staging CT, there is a type 3 GOJ tumor, but no local regional metastasis, so staged as T3N0. But they did notice that there was a low density lesion in the left liver lobe. This was also visualized in an MRI and measured at around 2 centimeters or so, with a little bit of intrahepatic duct dilatation. However, when we did do a staging PET-CT scan, the primary tumor in the GOJ was FDG avid with an SUV max of 12. Again, there was no metabolically active regional lymphadenopathy or liver lesions. So her case progresses to the central multidisciplinary meeting, where she was staged as metastatic disease by virtue of this liver lesion. And a couple of days after this initial MDM meeting, her pathology result from her local hospital that diagnosed this confirms that this is indeed a moderately to poorly differentiated adenocarcinoma with intestinal histology, and it was found to be HER2 positive at 3+ on IHC. So at the time, this was June 2020. So in terms of standard of care, as Noreen has mentioned, the TOGA study, which incorporates trastuzumab on top of the platinum and chemotherapy backbone, was definitely a standard of care option for her. But at the time, we were recruiting into the Keynote 811 study, which looked at the addition of pembrolizumab to this combination. So given that she was a good trial candidate with a PS of 0 and also with limited comorbidities, she opted to start screening for the Keynote 811 study. Now, these were her pathology results. At the very top, that's the initial result that came from her local hospital who organized the endoscopy, and that was HER2 3+. Secondly, below was our internal histology review here at the Marsden, and that actually showed that she was HER2 negative with a score of 0. These were done on the same biopsy tissue. And then we sent her tissue for central testing on the 811 study. And this actually showed that she was HER2 2+ by IHC, but she was FISH negative. So she therefore, unfortunately, failed screening on the study. So we had to carry on. She was started on first-line cisplatin and capecitabine with trastuzumab in August of that year. And as you can see, after 6 cycles of trastuzumab, she did have a response in her primary tumor, as well as her liver metastasis. Her CEA was elevated at baseline, and that also showed a degree of response. At this point, she was rediscussed at the multidisciplinary meeting. And actually, it was felt that the MRI that she had at the end of her 6 cycles, MRI liver, actually showed that, yes, the MRI, the lesion in the liver was persistent at 10 millimeters, and actually wasn't amenable to surgery or ablation. However, there was a response in the primary, so it was decided that we would offer her consolidation radiotherapy to the primary and also continue trastuzumab as maintenance therapy, which is what she had in 2021. Unfortunately, we then detected disease recurrence in October of that year, and while she was on maintenance trastuzumab, so she was recommenced on a cisplatin and capecitabine re-challenge. Now, at the time of recurrence, it was actually noted on her imaging, both MRI as well as CT, that there was no evidence of liver metastasis, and that looked normal. And that pretty much persisted throughout her cisplatin and capecitabine re-challenge. There was a degree of response in the primary tumor, and she was also found to have a new gastrohepatic node. It was small, it was only 10 millimeters in the short axis, and by mid-treatment, it was no longer evident. In February, her end of treatment PET CT scan only showed that she had metabolic disease in her primary, but the gastrohepatic node was not visible. So at this point, we've got a patient with a persistent primary tumor, which has responded to treatment with no evidence of metastatic disease on MRI or PET CT scan. So what will you do next? So got 19 responses. So the minority of you would continue chemotherapy with trastuzumab, and about half are saying continue trastuzumab maintenance, and half say discuss the feasibility of surgical resection. We did the latter. So she was discussed at the MDT again, and it was felt that at this point she had disease that qualified, that met criteria for surgical resection. And that's what we did. She had a total gastrectomy, splenectomy, and cholecystectomy. And even on path, you can see that she had really bulky disease in her primary tumor. So she had PT4-PN2, fully resected tumor from the stomach and the fundus involving the gallbladder. And a month later, she has no measurable disease on CT scan. So we embarked on a period of surveillance. However, she was then found to have an elevated CA99 of 195 in May 2022. We proceeded to restage her by PET, and it did show that there was some uptake in the right lobe of the liver that wasn't there before. This was further characterized on MRI, and it was sort of described as potentially a post-operative collection of an abscess or perhaps recurrent disease as the CA99 was raised. As the patient was well, we decided to do an early interval scan to see if there was any change in this. And this is what happened a month later. Unfortunately, her CT scan actually showed that she had multifocal disease progression in her pleura, her peritoneum, her liver, and her anterior abdominal wall where her surgical scar was. And that's where we took a biopsy, and again, it confirmed adenocarcinoma, which was HER2 positive 3++ by IHC. So at this point, this was just a few months ago, it's 4 months ago, granted the updated ESMO gastric cancer guidelines for 2002 weren't quite published yet, but these are our current treatment options in the second line at the moment. Paclitaxel and ramucirumab, ramucirumab monotherapy for patients who cannot tolerate paclitaxel, or taxane or irinotecan on their own, which is on the NHS what we do, as ramucirumab is not funded, or if they are DMMR, then to consider pembrolizumab on its own. Again, Noreen's mentioned the Destiny Gastric 04 study, which is a randomized phase 3 study recruiting patients with HER2 positive disease to either PACRAM or trastuzumab deruxtecan. And again, because she remained well and she was a good trial candidate, she opted to screen for this. Unfortunately, once bitten, twice shy. In terms of her central testing, again, unfortunately, she failed this again by virtue of that she had HER2 1+ disease by IHC this time. Now, the patient had private healthcare insurance, and we did apply for trastuzumab deruxtecan, but unfortunately, they declined that application as there was no actual second-line evidence to support its use. So she didn't commence paclitaxel and ramucirumab in the second-line setting through private insurance. And she's currently on that, and we await the first response assessment from that as well. So this is a very similar graph to what we've already seen. Noreen's already mentioned that, the overall survival with first-line chemotherapy on its own for OG adenocarcinoma, you really can't push past that elusive 12-month mark with chemotherapy alone. But what we know from TOGA, which is the bar that's starred with in red, is that the addition of trastuzumab to these patients who are HER2 positive will shift this and increment that benefit to 13.8 months. And what we've also seen in the HER2 negative patients is that the addition of nivolumab to chemotherapy in CPS high patients will further increment that and improve that to 14 months. So what we know now increasingly is that biomarker directed therapy in OG cancers is very important. So just to reiterate, TOGA was a seminal study that was published in The Lancet in 2010 that took on HER2 positive patients. So in terms of the definition of HER2 positive for the intention to treat population, that was with HER2 IHC 3+ or FISH positive using a HER2 CEP17 ratio of 2 and above. However, it was really the subgroup analysis that showed that median overall survival is about 4 months better in patients who are at least HER2 2+ and FISH positive, or IHC 3+. So that really is a definition that is used for HER2 positivity in OG cancers from there on now, and used to determine clinical trial eligibility going forward. It's probably worth mentioning that I think in terms of NICE funding in UK practice, that trastuzumab and chemotherapy is only funded for patients who are IHC 3+. So patients who are IHC 2+ but FISH positive, unfortunately, on the NHS cannot access trastuzumab. What we saw with this patient was actually that she obviously had lots of differing IHC results. So, OG cancers are very heterogeneous, and it's made actually the development of targeted therapies incredibly difficult. So really, this is an excerpt from the American Pathology guidelines, where they actually say that because of heterogeneity, that they would recommend that a minimum of 5 biopsy specimens are tested for HER2 positivity to account for this intratumoral heterogeneity, and they would ideally like 6 to 8 specimens to ensure that they can fully fully assess this for biomarker testing. And why is it important? So this is actually a prospective German study that was published, I'm sorry, that reference is erroneous, that was published over the past 12 months by Hafner et al. In the JCO. And they recruited over 500 patients around Germany and actually compared central HER2 testing against their local results. So as you can see, looking at the Kaplan-Meier on the left, patients who had concordant disease, both positive at central and local testing. So the teal line at the top of that curve, you can see that actually their overall survival is much better than patients who were either negative in both central and local testing, negative in central testing, but local testing was positive, or if they were centrally positive, but local testing was negative. So really, it's this very strongly positive patients that will benefit from trastuzumab, and it underlines and reiterates that expression is very important. They then looked to see if they could figure out an optimized IHC threshold, or also a optimized amplification threshold. And what they found was that if you dichotomize the patients using a threshold 40% of positive cells using IHC, again, you're able to see a significant difference in survival. And similarly, if you have an amplification ratio of, a FISH ratio of over 3, again, you're able to differentiate better responders from those who will not. So HER2 expression and amplification, determining this correctly is very important. So, we've mentioned a few trial designs. Noreen's also touched on them. But again, so Keynote 811, the results, the final analysis results are currently awaited. But this was a phase 3 study that randomized patients to either pembrolizumab or placebo on top of chemotherapy and trastuzumab. So the first readout from this was from an interim analysis where the efficacy group that consisted of about 260 patients had a median follow-up of about a year. And it basically showed that the overall response rate with pembrolizumab was 75% against 50% with the placebo group. In terms, more patients also had a complete response on pembrolizumab, so that was 11 versus 3%. And at the time of data cutoff, there were more patients with ongoing treatment in the pembrolizumab arm. So we know that we can access this or rather patients in the US can access this as it's gotten accelerated approval by the FDA last year. But, it's always a little bit, I suppose the overall survival data has not been published, so we do not know if this will definitely translate into a survival benefit. So briefly as well about trastuzumab deruxtecan. So this is an antibody drug conjugate, and they are a class of drugs where the efficacy really relies on target expression and internalization of the cytotoxic payload. So trastuzumab deruxtecan comprises of 3 different parts. One is a humanized antibody that is similar to trastuzumab, and it's linked by a cleavable linker to a topoisomerase 1 payload. So it therefore hones into a HER2 positive cell. It penetrates this cytotoxic cell and it gets cleaved within the cell where its chemotherapy payload is released. And that is how it also causes cell death. Now, you may be wondering, we've looked, the Gatsby study showed that trastuzumab emtansine, which is also an ADC, was negative in the second line in OG adenocarcinoma that was HER2 positive. So why is this different? So one of the more unique features of trastuzumab deruxtecan is that it has something called a bystander effect, where it's able to seep into neighboring cell death and cause cytotoxic cell death that way. And I suppose the reason why that's useful in gastric cancers is because of this heterogeneous staining that we've seen with this patient's case. So actually there is some data from one of the earlier studies suggesting that even HER2 low disease may have a bit of clinical activity in patients who are only IHC 2+. So this is definitely quite an interesting drug and very interestingly designed. So So Destiny Gastric 01, we've seen this waterfall plot already, but it was really the first randomized study that showed an improvement in survival in HER2 positive patients that previously had treatment. Now, there was an Asian population, as Noreen has mentioned, but it did show that the overall response rate was about 40 versus 12%. And actually in this Asian population that was very heavily pre-treated, that the median overall survival was 12.5 months. So, in terms of treatment disposition of these patients, about 55% of them had this treatment as third-line chemo. And then about 30% of them had it as fourth-line treatment, and the rest were fifth-line and beyond. Granted, this is an Asian study, but it definitely showed that there was some activity there. So it is approved in Asia and as well in the US, but not quite yet in Europe. And Noreen's also already mentioned that there is a 10% risk of interstitial lung disease, and that may be because there is independent uptake of TTXD by the alveolar tissue as well. In the Western population, there has been publication of a single-arm trial of trastuzumab deruxtecan in about 80 patients, and this showed an overall response rate just shy of 40%. So, which really leads us on to the Destiny Gastric 04 study that our patient was considered for. Now, what this will, see if it is actually superior to paclitaxel and ramucirumab in the second-line setting. And unlike Destiny Gastric 01, what is also quite different in this study is that they actually mandate that the patient is rebiopsied after progression on trastuzumab to confirm HER2 positive status. And obviously it's also a second-line study other than third-line. But, I think in terms of, there are lots of other different treatments that are being trialed in HER2 positive cancers, but really, I think trastuzumab deruxtecan looks very exciting, and may actually change the way that we treat HER2 positive patients who have had previous treatment. So on a final note, we obviously, this patient was considered for surgical resection in the context of oligometastatic disease. And this is an, emerging area in the management of advanced esophageal adenocarcinoma. We obviously consider it more strongly in colorectal cancers, but the evidence for it in gastric cancers is a lot less robust. The only randomized study in this space is called the Regatta trial. This was an Asian study of about 170 patients who had advanced gastric adenocarcinoma with a single non-curable metastasis, either in the liver, the peritoneum, or a para-aortic node. And they were randomized to receive either S1 or cisplatin, or they had a gastrectomy with a D1 lymphadenopathy rather than a D2, as well as chemotherapy. Now, this trial closed early after an interim analysis showed that futility, and they actually showed that patients at chemotherapy, rather than a gastrectomy and chemotherapy, had a better overall survival than those who had surgery. Now, I think what this study did was actually, what they wanted to do was to see if a resection of a primary tumor in advanced disease would actually improve outcomes, but they did not mandate that the metastasis had to be resected as well. So really, in spirit, this was a palliative study rather than a curative study. And they also did not mandate that a D2 lymphadenectomy, which is very important in curative resections, would be done as well. This second study is the FLOT3 study, so run by Albertran's group as well. And this was more of an observational study where they recruited 3 different categories of patients into 3 separate arms. So in the first arm, this patients had resectable disease where they had perioperative FLOT and chemotherapy and surgery. In arm B, they had what was defined as limited metastatic disease, where they, for example, had 1 abdominal or retroperitoneal lymph node, or 1 incurable organ site without retroperitoneal lymph node metastasis, and as well as no visible peritoneal or pleural disease. These patients with limited metastatic disease went on to have a neoadjuvant FLOT, as well as surgery, but that was only if a full R0 resection is possible and at least a macroscopic resection of metastatic lesions was possible. And then you have arm C, where patients have extensive metastatic disease, where they would receive FLOT in the palliative setting, and if required, for palliation, they were allowed to have surgery. So in terms of results, what they actually showed was that patients in arm A, you would expect have resectable disease. So as you would expect, the median overall survival was not reached. But in comparison, patients with limited metastatic disease who went on to have surgery, who were eligible to have surgery, it was appropriate, had a median overall survival of 22.9 months. When you break it down into patients in arm B, where they actually felt that surgery was feasible, again, in these patients with limited metastatic disease, that the median overall survival was 31.3 months. In the context of a disease type where your median overall survival with chemotherapy alone is about 12 months, that obviously looks quite impressive. But this was an observational study. And the patients who were deemed fit for surgery were obviously a fitter population of patients who had responded to treatment. So you would expect that there would be a improvement in survival with surgery compared to no surgery. So where does that leave us in the scope of developing oligometastatic disease and understanding how we treat them in OG adenocarcinoma? So this is again leading on from the FLOT3 study. This is the FLOT5 study, otherwise known as Renaissance, where patients with limited metastatic gastric or GOJ adenocarcinoma are recruited into the study. They will receive 4 cycles of FLOT chemotherapy and then go on to be randomized to surgery and adjuvant FLOT, or to continue with FLOT itself. So this is currently recruiting, and it's one of the awaited readouts as well, so we can better define what we do with patients with oligometastatic disease. So that's the case. I think it's quite interesting. It highlights lots of different novel therapies, the challenges in treating HER2 positive disease in the advanced setting, and also scope for oligometastatic disease management as well in this tumor type. So thank you very much for listening.
Thanks a lot, Caroline. That was really excellent. The heterogeneity about HER2, that's something to keep in mind. We often forget about that, particularly now with this kind of TDXD drug and this concept of HER2 low. We can move on to there is actually a question related to that. Hira Youssef asks, are there any future studies or current studies for HER2 low gastric cancer, like Destiny-04 trial running for HER2 low breast cancer, showing promising results for TDXD?
Off the top of my head, no. I think it was Destiny Gastric 01 that had some exploratory groups with HER2 low, both in IHC 2+ and an IHC 1+. And I think that was again in 3rd-line setting. And in the IHC 2+ positive group, the ORR was 25% in a 3rd-line setting in Asian patients. So as far as I'm aware, there is no upcoming trial for this, but it is interesting because it opens up a whole new paradigm for these patients. Those are patients you would normally treat as HER2 negative. But as far as I'm aware, no, I don't know if Waz or Noreen know otherwise.
No, I agree with you, Caroline. I think Destiny Gastric 003 for the first one, I get confused with all the 00s, but anyway, it's a first line study is again focused on the HER2 3+ group, and we have to, you know, send everything and re-biopsy, and that's a first line setting. So I don't think so.
Thanks. So Amal asks, hi Caroline, would have it been possible to continue trastuzumab during the perioperative phase and postoperatively with the patient in the case?
Yes, so she actually had trastuzumab leading to, well, right up to the operation. I think at that point it was decided that while she didn't have any metastatic disease that was visible radiologically, that the tumor had responded to an extent to chemotherapy, but we maybe had reached a point where we might not be able to elicit any more of a radiological response in the primary tumor. It had always been very stubborn, despite everything we've thrown at it. So it could have been a consideration. I don't know, Noreen, I think this was your patient. She always had good enough cardiac function to continue that, but there was nothing to treat at that point.
And to be honest, as per on the NHS side, as per their sort of indication with trastuzumab, we wouldn't have had funding, so surgery put a stop on that pathway. You know, you try and select out the best patients. In fact, this actually was patient-driven, family-driven. She said, look, come on, I'm nearly 2 years down the road and it's just here, and why wouldn't you think about surgery? And so we took her case to the MDT, patient-led. And I did ask her when everything sort of blew up afterwards, did she regret having gone down that path? And, you know, we advocated her and pushed for it. And she didn't, actually. I do reflect on whether, you know, the act of surgery, somehow everything has accelerated since then. And we sometimes do see that in different contexts. So I sometimes do reflect, was that the right course of action? But she and the family are very happy with what happened.
Yeah,
that's great.
That's a good point, that this was very much patient driven.
I guess it has to be selected on a case-by-case basis in these kind of situations. So thanks everyone for attending this evening's webinar. On behalf of the speakers and everyone at the ACP, thanks again, and good night.